Hello, I'm Ramin Tadayoni, and I thank very much organizer for having invited me to talk about novel approaches for optimizing neovascular AMD management. Here are my financial disclosures. When our current treatment have been a revolution in the treatment of AMD, we still would love to have better treatment and better visual results. Everyone, companies and doctors, we are all working to achieve this. We have some promising results at phase 2 trials, like with OPT 302, that shows some promising results with improving vision compared to the regular treatment. But often at phase 3, we just have non-inferiority result like here, showing that we can achieve the same visual result, but sometimes with a better durability. However, better durability may be important, and we know from a few studies that regimen and being able to treat the patient on time is as critical as the molecule itself. In this study, when patients were switched from PRN to treat and extend, because the treatment interval was improved and the treatment was better done, so the visual acuity was improved. So there is a link between durability and the regimen. Until now, because treat and extend allowed to achieve a better treatment in most of the patients, this has been the most popular regimen, and this has been the main way in which we try to improve the result of our treatments. It seems complicated, but basically, if we look, it's quite simple. You treat the patient until you achieve the better result, and then try to extend by 2 weeks until you see a recurrence or something that you don't like. Then you go back to 2 weeks shorter. And you can increase the interval until we don't know how much, usually 3 months or 4 months and not more. Borusizumab, by being smaller, allowed a higher molar dose of injection, and by this, try to increase the interval of injection. And indeed, after a loading dose, patient could have injection every 3 months. But if there was a recurrence, for example, at 8 weeks after the loading dose or any time during one of the injection, the interval was reduced to 8 weeks. Some kind of treat and reduce instead of treat and extend. By this regimen and this molecule, half of the patients were treated every 3 months after the loading dose, immediately after the loading dose during the first year. So we see here a potential to improve the result in real life. Faricimab, by inhibiting not only VEGF but also angiopoietin-2, was also able to increase the interval of injection. The regimen here is also very interesting. After the loading dose, depending on the time of recurrence, patients had injection every 4 months, 3 months, or 2 months. 80% of patients needed an interval of larger than 3 months, and nearly half of them, 45%, achieve interval of Q16, then 4 months right after the loading dose. Of course, the molecule and the regimen at the end was non-inferior to aflibercept Q8. But by increasing the interval, we may hope better results in real life. PDS is another way to increase the interval. A reservoir is put in the eye surgically and filled every 6 months. By doing this, patient needs no or very few injections. For example, in this study, over 2 years, patient needed 5 times less injection than without the device. Basically, a few injections during the 2 years. Here also, we can expect better results in real life. Other molecules are also experimented, but they are less advanced. For example, this molecule from Kodiak Science that in 1 year has shown that in AMD, after the loading dose, patients only needed 2 injections. These are very promising results, and other molecules have also promising results. Gene therapy is another way to reduce the need of injections. Here you make the eye produce its own drug, and 2 molecules are quite advanced. And in phase 1 trials, they have shown that it's possible not to inject patients. there has been a few inflammation that has been well treated by steroid drops. And then comes the conclusion. Yes, new therapies may also mean new adverse effects that can be seen during the trials or during the real-life use, as for brolucizumab, in which a few cases of vasculitis has been described. Then comes the need to a benefit-risk ratio evaluation for each of them to see if the benefit is higher than risk and who are the patients who need these new therapies. So we'll need to collect real-world data to see if the efficacy is improved by longer durability and if the safety of agents is similar to the trials. Thank you very much.